All right, so we will start with prostate cancer today, and I'll share the screen with you. All right, so can you see the screen? No answer? I hope you can see the screen. Please confirm. I don't have...
Yes, Doctor, we have seen you.
All right, so I hope you are there. You're not in the other room and switched on the or logged into the lecture. Nobody replied to me. Anyway, I'll start with prostate cancer, and you see that the symbol for prostate cancer is this blue ribbon. In breast cancer, we saw that the symbol of breast cancer awareness was a pink ribbon. So September is the prostate cancer awareness month, so we are having this lecture at the right time. Let's start with the overview. Prostate cancer represents the second most cancer worldwide among men, and it is the fifth most common cause worldwide. But in developed countries like in USA, prostate cancer is the most common cancer in men, and it is the second most common cause of death after lung cancer. Acinar adenocarcinoma of the prostate comprises 90 to 95% of the prostate cancers. Now, what is an acinus, and what are the cells in there? Well, usually you find acini in the glands, and I'll show you histology. A schematic view of the acinar in the coming slides, so you will understand where exactly which cells turn cancerous and where the cancer arises from in 95% of the cases. Ductal carcinoma, you remember we had ductal carcinoma in breast cancer as well, and neuroendocrine carcinoma account for the majority of additional cases. Now, there are hardly any additional cases because 95% are adenocarcinomas, so and they arise in the acini. So ductal carcinoma constitute a very small number of prostate cancers. All right. So a little bit about the anatomy of the prostate cancer. This is the prostate, and you can see that it is right under the bladder. Here is the urinary bladder, and this is the urethra. So the important point to note over here is that the urethra passes through the prostate gland. Okay, and then I've shown you the rectum over here, and the reason for showing you the rectum is that it's very close to the prostate gland. It's almost touching the prostate gland. So if you want to examine the prostate gland, or if you want to look at the enlargement of the prostate gland, you can palpate through the rectum. All right, this is known as digital rectal examination. And then we have this seminal vesicle. This too has duct. You see there is a duct coming from the testes. This is known as vas deferens, and the duct from the seminal vesicle, they both join the vas deferens, and then they join the urethra through the prostate gland. Okay, so and we'll come back to this figure when we do benign prostatic hyperplasia, because when the prostate gland enlarges, it compresses the urethra. But sometimes, depending upon the location of the prostate cancer, in this lecture we are doing prostate cancer, sometimes if the cancer is close to the urethra, it can cause some symptoms with the urine, which are known as obstructive symptoms. All right. The weight of the normal prostate gland is about 20 grams. Some folks might write 15 grams or 25 grams, but on average, it's around 20 grams. Now, prostate gland is composed of different types of tissues, and based on those tissues, it is divided into zones. Prostate gland also has lobes, but I've not shown you the lobes over here. It has got anterior lobe and lateral lobes and the posterior lobe. But what I've shown you in this diagram are the zones, and the zones are divided according to the type of tissue they have. For example, this fibromuscular zone which I've shown you over here, it does not have any glandular tissue. It is mostly fibromuscular tissue, fibrous tissue, and some muscle tissue over here. Now the peripheral zone, this is the peripheral zone. Okay, it's a very large area. Then we have got the central zone, and we have got the transitional zone. Now, from the point of view of prostate cancer, these three zones are important. The peripheral zone contains the bulk of the prostate gland and is located at the back of the gland. So in the previous figure, I showed you that the back of the gland is almost touching the rectum. So when you palpate through digital examination, you are actually palpating the peripheral zone. And the peripheral zone is important also because the majority of the prostate cancers, about 70% of the prostate cancers, they arise in the peripheral zone. Then we have got the central zone, and the central zone is important because the seminal vesicle and the ejaculatory duct that brings fluid from the seminal vesicle, and it brings sperms from the vas deferens, they pass through this. Okay, so this area accounts for about 15% or 15 to 20% of the cancers of the prostate gland. Then we have got this transitional zone, which is yellow in color. It surrounds the urethra, as you can see over here. Okay, now if the cancer is there in this place, which is not very common, it is about 10% or say 10 to 15%, or some books write less than that, 5%. But the important point to remember over here is that when the cancer arises over here, it's very close to the urethra and it can extend into the bladder. All right. So, and this area grows throughout the life, and it is responsible for benign prostatic hyperplasia as well. Now, going back to the first slide in which I said that we have got acinar adenocarcinomas in 95% of the cases. So that's what I'm going to show you. If you look at the prostate gland or the sections of the prostate gland under a microscope, you will see these gland-like structures and acini. And these are the cells of the acini. They produce the prostatic fluid. The prostatic fluid constitutes about 20% of the ejaculate in the male. All right. So here is a blown out view, and these are the cells that are producing the prostatic secretions, and these are the cells that become cancers. Okay, we call it adenocarcinoma because it arises from a glandular cell. And as the cell becomes cancerous and it divides and divides, it will destroy all these cells, and it will damage or destroy the structure of the gland, and it will fill this gland with cancerous cells. Okay, but it depends upon the differentiation of the cells. They could be well differentiated, they could be poorly differentiated, and we have discussed this aspect in the previous cancers as well. All right, and I'll come back to this later on. So the background is that there is marked variation in the rates of prostate cancer, and because of this marked variation, we think that the genetic factors are involved in prostate cancer. And of course, there is familial predisposition, which again indicates involvement of genetic factors. Environmental factors play a role in development of prostate cancer, notably the diet. Again, red meat is the suspected culprit over here. Then the majority of the prostate cancers are identified in patients who are asymptomatic, right? So if the patient does not have any symptoms, how will you diagnose cancer in him? He is not going to go to the doctor. So that is why the guidelines recommend screening at a certain age, and I'll come back to screening. So what do we do in screening at a certain age, say at the age of 45 or 50 years? You measure the PSA levels. It is recommended that males should measure this PSA level. There are some males who are at higher risk than the other males. So they should, those who are at a higher risk, they will measure the PSA levels at a younger age. And I'll come back, I'll show you the guidelines for screening. Or another way in routine examinations of males who are about 45, 50, 55 years old, the doctor can do a digital rectal examination. And through these examinations, we can get an idea of whether a cancer is developing in the prostate gland or not. So, but this screening is controversial because screening sometimes leads to greater positive findings and poor treatment of the patients. But anyway, this is how screening is recommended in the guidelines. And remember that after screening, we have many other follow-up investigations that we do to confirm the presence of a cancer. So let us suppose that on screening, you do find prostate cancer, then you have to assign a grade and you have to assign a stage. Now, the grading in prostate cancer is quite different from what we have seen in breast cancer or lung cancer or colorectal cancer, and also in Hodgkin lymphomas. So it is quite different. It is based on a Gleason grading system that I'll show you later on, okay? So quickly, Gleason grading system has two numbers. We look at the most prominent appearance of the prostatic tissue and the second most prominent appearance that I'll explain to you later on. You'll understand what I'm trying to explain to you. And then you assign a grade of 1 to 5. Okay, so you're assigning two grades, one to the most predominant pattern and another to the second most predominant pattern. Okay, all right. So let's go on to the pathophysiology. Following initial transformation event, further mutations of a multitude of genes, including P53 and retinoblastoma, lead to tumor progression and metastasis. And we have seen this in all types of cancers. Why do the cancers start? Because there are mutations in on proto-oncogenes, oncogenes, and they have increased function and increased expression, or there is silencing of tumor suppressor genes. Both of these are tumor suppressor genes. Tumor suppressor genes should not be inactivated because they protect against cancers, all right? So, and once the cancer starts, because of mutations in 3, 4, 5 genes, as we have seen in colorectal cancer, then further mutations start occurring, and some of these mutations will make the cancer cell more aggressive. Some of these mutations will be less favorable. They might kill the cancer cells, but the dangerous mutations are those mutations that make the cancer cell more aggressive, and that make the cancer cells more favorable for survival in the environment. Okay, so the mutations, they go on happening. Okay, it is like a domino effect, you know, one mutation after another, and some cancer cells become more aggressive. The squamous cell carcinomas, they account for less than 1% of all prostate cancers. And as I have mentioned, that 70% arise in the peripheral zones, which is on the posterior aspect of the cancer, 15 to 20% arise in the central zone, and about 10 to 15% or less than that arise in the transitional zone. And you see that the urethra is passing through the transitional zone, and you also note that the ejaculatory duct coming from the seminal vesicles also passes through the central zone. So any cancer in the central zone has potential to spread to the seminal vesicles, which is not a good thing, okay? And most cancers are multifocal with synchronous involvement, which means that cancers could arise in different areas or different lobes of the prostate gland. Now, local spread and metastasis is important, and I've already referred to that. The transitional zone, which is this one, the cancer in transitional zone spreads to the bladder neck, and here is the bladder. Peripheral zone tumors, which is over here, they can extend into the ejaculatory duct, but the central zone tumors have a higher possibility or probability of spreading to the ejaculatory duct and into the seminal vesicle. Now, local spread could involve the penetration through the prostatic capsule which means, around the prostate, there is a capsule. So penetration into the capsule is not a good thing. It means that the volume, we look at the volume of the cancer or the penetration of the cancer. So this means that the cancer is a little bit more advanced compared to that cancer which does not involve the capsule, okay? And cancer can spread into the nerves that are coming to the prostate gland, into the blood vessels that are coming to the prostate gland. And the characteristic of prostate cancer is that it spreads to the bone at a very early stage. And in many cases, as you will see later, we diagnose prostate cancer when the patient presents with bone pain, for example, pain in the leg or the lower back pain in the spine, which are very common places for the spread of prostate cancer, right? Now, incidental and unsuspected diagnosis when you are doing some surgery for the bladder, or you are doing some surgery for benign prostatic hyperplasia, and you remove prostate gland as well when there is cancer of the bladder. So incidentally, you find prostate cancer of the prostate as well, although you did not do the treatment for prostate cancer, all right? And it increases with age. There have been studies in which they have done autopsies in people who died of some other diseases like infections or heart diseases. And when they examined their prostate, they found prostate cancers. But those prostate cancers were very low Gleason grade cancers, and they were not symptomatic, and they did not cause any problem to the patient, okay? As it is written over here that low Gleason grade, which is 6, 5 is not considered as cancer. It requires 10 to 15 years or perhaps even more to develop into an aggressive disease, or it may never develop into an aggressive disease. It may remain localized without causing any symptoms, okay? So that is something different about prostate cancers than other cancers. Prostate cancers could remain localized and asymptomatic for 20, 30 years and never produce any symptoms or any problems, okay? But high-grade cancers, they progress, and they can involve the capsule, they can involve to other tissues, they can spread to the bladder, to the bones, and other tissues, okay? And Gleason 5 is not considered cancer. So far what we have done is I've given you a brief overview of the cancer and gave you the anatomy and gave you different zones of the cancers. I mentioned where the cancer arises in 95% of the cases in the glandular cells which produce the prostatic fluid. Then I gave you some background about genetic factors, and once we diagnose a cancer, we assign a grade and Gleason score that I'll come to later. Then I gave you a little bit of pathophysiology about the percentages of cancers in different zones and local spread. And of course, we described the lower and the higher grades and how long do they take to become aggressive cancers, all right? Now we go on to epidemiology. Ethnicity is important because prostate cancer is twofold higher in blacks or people with African genes than in whites. Age, the older the age, the greater are the chances of getting prostate cancer. Country of origin, it is low in Asian men like the Chinese people or the Japanese people, the Eastern, the people in the East, okay? Family history of prostate gland increases the risk by 68%. If the brother or the father had prostate gland, then obviously the risk is high. Now, this is strange. First degree relative with breast cancer. If a woman in the person's family has got a mutation in the BRCA1 or BRCA2 gene, then the risk increases in the male for the prostate cancer because BRCA1 and BRCA2 genes are involved in development of prostate cancer, okay? Increased BMI, metabolic syndrome, increased waist circumference, these are all the risk factors. Tobacco smoking is a risk factor, all right? Now, germline mutations, I've mentioned that BRCA1, BRCA2 genes, this ATM means ataxia, telangiectasia mutated. You don't have to memorize the name, but you must know that this is known as BRCA gene, breast cancer gene, okay? And this breast cancer gene is not only involved in breast cancers, it is involved in many other cancers like ovarian cancer and prostate cancer and colorectal cancer as well. Okay, so this, if there is a mutation in this gene, there is a high risk of prostate cancer. Lynch syndrome, if you remember from colorectal cancer, HNPCC, hereditary non-polyposis colorectal cancer. Those people who have that cancer have got a twofold higher risk of developing prostate cancer. In men referred for genetic testing, 20% have known genetic variations, but you know, the facility for genetic testing is not available everywhere. It is available only in very specialized units, okay? There are many other germline mutations, but we don't need to go into those details because genetic testing is not done very widely in, you know, this is the most common cancer among men, particularly in developed countries. That is why this cancer is very important, but unfortunately, we do not have the facilities to test all these genes, okay? And I've given you an explanation and functioning of these genes, but this is for your reference only. Every slide that is for your reference, I'll just quickly go through that slide. Now, prognosis is very important. You know, once a person is diagnosed with prostate cancer, what is the probability of his survival? How long will he survive? And like in any other cancer, it depends upon many things. You know, the other cancers, they mainly depend upon the stage of the cancer and the differentiation or histology of the cancers. But here, there are many other things that we take into account. For example, Gleason grade is a measure of the aggressiveness of the cancer, but Gleason grade is further divided into grade groups, or based on Gleason grade, we assign grade groups to the patient, okay? Tumor volume is important. I said that the tumor could spread to the bladder, the tumor could spread to the seminal vesicles, it could penetrate into the capsule, or it could penetrate outside the capsule into the neighboring tissues. So tumor volume is important. Capsular penetration and margin positivity after prostatectomy, that if you get positive margins that I've shown you in other cancers as well, then obviously you have to do, sometimes you give radiation therapy. So high-grade prostate cancer and seminal vesicle invasion are associated with disease progression, okay? And also capsular penetration. 30% of localized cancers are estimated to progress despite an initial treatment with intent to cure. And we have seen that this happens in all the cancers. And why does this happen? Because those cells that have been left behind, they develop more and more mutations, and they become more and more aggressive, and they become more and more resistant to treatment. Okay? So PSA, at the initial stage, if the PSA is very high, the pathologic stage of the cancer, the histologic grade, which is essential, the Gleason grade, these are important. Smoking, a number of pack years, you know, last time I said that 20 cigarettes per day for 1 year is 1 pack year. Okay, so that has got poor prognosis. Now we do risk assessment of the patient. And this is one of the models for risk assessment. It is known as CAPRA, cancer of prostate risk assessment. So we measure the PSA level, Gleason score, and grade group, percentage of positive biopsy course. Now, when I come to the biopsy, we'll see, you know, in prostate cancer, we take a number of needle biopsies, 12 to 20. Okay, and we see how many of them have cancer cells in them. Then clinical tumor stage, age at diagnosis, stromal invasion. I've mentioned that many times previously. Now, prostate cancer can arise from transitional cell cancer of the bladder, and that has got a poor prognosis. This means that the bladder cancer has spread to the prostate, and it has even invaded the stroma, stromal tissue, non-glandular tissue in the prostate gland, and that has a poor prognosis. But that is basically a bladder cancer, okay? And this is a reference. If you want to go into more details of molecular prognostic markers, you can refer to this. Now, again, this is for your reference patient education. If you want to go into more details, you can read it, okay, on your own. So clinical presentation on the local disease, that is a problem. We are not discussing the local disease. Later on, we will go on to the metastatic disease, okay? Local disease, most of the times, is symptomless. Majority of the patients are identified in majority of the prostate cancers are identified in patients who are asymptomatic, right? So how do we know that they have cancers? By screening. And what is screening? Screening is prostate-specific antigen testing. You measure the level of prostate-specific antigen, or you do a digital rectal examination if the patient comes to you for screening, okay? See, in Saudi, you have a population of, say, 20 million. Out of these 20 million, let us suppose that there are 10 million males. Out of those 10 million males, let us suppose there are 5 million or say 3 million who are above the age of 40 or 45 years. Now, all of those 3 million are not going to go to the hospital for screening, okay? So that is why, you know, the patients remain asymptomatic. Sometimes the cancer progresses and they become symptomatic and they get more aggressive cancer and then they come to the hospital. Or sometimes, you know, they remain asymptomatic and they never know that they had a cancer for their whole life, okay? So prostate cancer can be an incidental pathologic finding after surgery of benign prostatic hyperplasia, which is our next lecture. Now we go on to the advanced disease, okay? Advanced disease means the cancer has gone out of the prostate gland. And, you know, it goes out first to the bones. And which bones? It goes out most commonly to the spine, okay? But it could go anywhere, to any bone. So advanced prostate cancer results from a combination of lymphatic spread, hematogenous through the blood, or contiguous local spread. You know, it can go out of the capsule into the adjoining tissues, okay? Bone pain is especially common because prostate cancer has a strong predilection for metastasizing to the bone. So it is not uncommon that the patient would come with a low back pain, or if the cancer has spread to the lymph nodes, and mostly it is the pelvic lymph nodes, you know, prostate is in the pelvis, so it will be pelvic lymph nodes, or it could be inguinal lymph nodes. So the patient might have pain in the leg as well. So manifestation of metastatic advanced prostate cancers, it includes weight loss, anemia, neurologic deficits from spinal cord compression, which means that the cancer has gone to the spine, to the vertebrae. Lower extremity pain because of the involvement of the nodes in the inguinal region, and uremic symptoms. Now, if a patient has got many of these symptoms at the time of diagnosis, then the prognosis is bad. If the patient has got very few, just 1 or 2 of these symptoms, then the prognosis is better. I will not say good, I'll use the word better, because, you know, it is a metastatic cancer. And unfortunately, we do not have a cure for metastatic cancer. So this is what I've explained to you. I've given you a little bit of epidemiology, a couple of genes that are commonly involved and that make the cancer aggressive. I've given you the prognosis. We look at Gleason grade, tumor volume, penetration, involvement of seminal vesicle. Then we do a risk assessment. We look at more or less the same things: PSA level, Gleason score. If they are higher, then the risk is higher, okay? or the prognosis is not very good, tumor stage, then patient education is for your self-study or reference. Then clinical presentation, we said that in localized disease, the patients are asymptomatic, and most of the times it is diagnosed on screening or it's a chance diagnosis. And advanced cancer does have symptoms. Most commonly, the patient comes with bone pain in the spine or in the leg, and there are other symptoms that might lead us to do more investigations. Okay. Now we go on to physical examination, and again I've written for your reference only. Now in physical examination, the most important is digital rectal examination. There are many other things that we do routinely in other cancers. Cancer cachexia means weight loss in cancers. Bony tenderness, particularly in prostate cancer. Lower extremity lymphedema, or swelling of the lower limb, or deep vein thrombosis in the lower limb. Adenopathy means involvement of the lymph nodes. Okay. It could extend to the bladder, or it can obstruct if it is in the central regions or the transitional zone. Then where the urethra passes through there, it can obstruct the urine flow. But if it is in the peripheral zone, or if it is in the lateral lobes, then it is away from the urethra. It will not cause any obstruction. But these are the things we look for. Okay. Now the more important thing is digital rectal examination. And if the digital rectal examination, normally, when you feel the prostate through the rectum, it is smooth, right? And it is sort of not hard. Okay. Its consistency is something like not very soft, but it feels, the most important thing is that it feels smooth. Okay. But if you find some nodules or hard nodules over there, and if you are unable to feel the sulcus that I'll show you later on, then you suspect prostate cancer, and you can do other investigations. Okay, you can take a biopsy, or these days, there is an MRI that you can do before the biopsy to get further confirmation of the presence of cancer. Okay. If cancer is suspected, determining whether the disease is localized or extends out of the capsule. Now, how do you find out whether it has gone out of you do that through MRI. Okay. Obliteration of the lateral sulcus. Sulcus, normally when you are palpating the prostate gland, it is smooth, and you can feel a sulcus between the lateral lobes and the posterior lobe. If you don't feel that sulcus, which is a shallow groove, then, obviously there is something in it. Okay, so all these things combine, it's not just one thing. We combine all the examinations and all the investigations to make a diagnosis. Now, digital rectal examiner depends upon the experience of the examiner as well. Okay, if you feel a nodule on your palpation, you suspect malignancy, or you feel asymmetry or a difference in the texture, or you feel some bogginess. Okay, then these are important clues and should be considered in conjunction with prostate-specific antigen level. So you do a DRE and you find something, you feel that there is something abnormal. So the next thing you do is you do a prostate-specific antigen level. Okay. And you might do a biopsy. Okay, it depends upon the physician. So this is what digital rectal examination is. I explained to you that prostate is very close to the rectum. Okay, so that is why we examine or we palpate the prostate with a finger through the rectum. This is known as digital rectal examination. Differential diagnosis, it's not difficult. There are just 3 or 4 things in differential diagnosis. Acute bacterial prostatitis, prostatic abscess, benign prostatic hyperplasia, non-bacterial or viral prostatitis. Okay, tuberculosis of the genitourinary system. But these things have got their own signs and symptoms. Or their investigations in bacterial infections. You have got raised RBCs, or it will be painful. The patient will have high fever. Maybe same thing in prostatic abscess. Benign prostatic hyperplasia has got urinary symptoms. Okay, so the diagnosis is not difficult, and there is not much in differential diagnosis. Sometimes the patient can present with weakness of the lungs when the spine is involved and there is compression of the spinal cord. Okay, then obviously the patient is going to have symptoms in places which are being supplied by the nerves, by those nerves which are affected. Okay, now we go on to the workup for prostate cancer. Most of prostate cancers are identified by follow-up screening procedures in asymptomatic men. Again, digital rectal examination, prostate-specific antigen, transrectal ultrasonography, which is known as TRUS, transrectal ultrasound, okay, or ultrasonography. This is not a suitable examination. This causes false positive, which means overdiagnosis. So this is not a reliable test. Better than this are these PSA, DRE, or you can do an MRI, okay? But this transrectal ultrasonography, this TRUS, is very useful for taking prostate biopsies, okay? So when you are taking a biopsy, or when the doctor is obtaining a biopsy, he can use this transrectal ultrasound, okay? And we take needle biopsies. I'll come to needle biopsies later on. After you take the biopsy, you must send it to the pathologist for evaluating and for assigning a Gleason grade, okay? And now we have got 5 other grades of prostate cancer as well. Now the recommended tests are serum creatinine. The kidneys might be involved if it spreads to the bladder, or if it causes obstruction of the urethra. Liver function tests are important. These are all the baseline tests that you take before you start the therapy. Urinalysis for hematuria, CT, MRI could be done, germline testing if the facilities are available, and I've shown you so many genes that are involved or that could potentially be involved in prostate cancers. And there are some studies that do not provide useful information, which are blood tests. Other than PSA. PSA is important. Acid and alkaline phosphatase, although acid phosphatase these days some people say might indicate a poor prognosis. And chest x-rays, they are not very useful. These are the useful studies that you should do. Now we come to this, I've been saying prostate-specific antigen, measure the level of prostate-specific antigen. So what is prostate-specific antigen, okay? Prostate-specific antigen is a protein produced by normal as well as malignant cells. So normal cells that I've shown you in the acinus, the glandular cells that make the prostatic secretions. So why are they making this prostate-specific antigen? We need that. But when you have got a lot of cancer cells, because they are arising from the cells that make PSA, so the cancer cells also make a lot of PSA, and that is why we get a higher level of PSA in prostate cancer, but we get that in some other conditions as well. So PSA is basically an enzyme that is produced for the ejaculate to liquefy the semen and to allow the sperm to flow freely in the female reproductive system, right? And it has got another function. This peptidase, this enzyme, which is known as prostate-specific antigen, it also dissolves the cervical mucus. And you know that it is through the cervix that the sperms enter the uterus, and from there they go into the fallopian tubes. And PSA could be raised in prostate cancer, in benign prostatic hyperplasia, and in prostatitis. So we need a combination of tests. If it is very high, and we give therapy to the patient, it should come down very quickly. If, depending upon the therapy, most of the times we give androgen deprivation therapy. If the therapy is successful, it will fall down within a few weeks. Okay, it will come back to normal. But after coming back to normal, if it rises subsequently, If it goes up again, and I'll come back to this point, then that means that the cancer has recurred, okay? And if the PSA level after falling down rises again, we call that biochemical recurrence. All right, now this prostate-specific antigen, their levels have been divided into 4 quartiles. Below 22 nanogram per ml, between, that is the first quartile, okay? It is a cancer. You know, anything, the normal is, I'll give you the normal. But 22 is pretty high. So we have below 22, we have 22 to 50 nanogram, which is the second quartile, then 50 to 134 nanogram, that is the third quartile, and more than 134 nanogram is the last highest quartile. So as the PSA level goes higher, the prognosis becomes poorer, okay? It's not a good sign. Now, earlier screening is recommended, like in all other cancers, and early diagnosis is desirable. So, you know, I'll give you the age for screening, the recommended age. But if a person has got a family history, or he has got an African background or a genetic stock, African genes, those who have got germline mutations of BRCA1 and these genes, they should do screening at a younger age, if you know them, okay? And there is no PSA threshold. You know, you cannot say if a person's PSA level is 2 nanograms, you can't say that he doesn't have prostate gland. Even if he has got 1 nanogram, you can't say. So there is no cutoff point for, but the higher it is, the more confident you get that the person might have prostate cancer. If PSA levels continue to rise on repeated tests, I'll come back to this point, then we can take biopsies, okay? There are different indications for biopsies. So here are the guidelines, okay? And again, these guidelines are for your reference only for this National Comprehensive Cancer Network. They say that PSA and DRE should be done between the age of 45 and 75 years, and not above 75 years unless the patient is healthy. If the PSA level is less than 1 at 45, then you repeat that every 2 to 4 years. If it is between 1 and 3, you repeat that every 1 to 2 years, or you depending upon the level. So this is for your reference. Different colleges have got slightly different, more or less they are the same, but there are slight differences, okay? Now coming back to prostate-specific antigen, when it was first developed, the upper limit of normal was thought to be 4 nanogram, okay? But subsequent studies have shown that there is no PSA level that guarantees an absence of prostate cancer. Okay, for example, I'll show you over here that if the PSA level is 1 nanogram, which is very low, even with 1 nanogram, cancer can be detected in 8% of men if biopsy is done. But these cancers will not be aggressive. These cancers may not cause any problem for the whole life of the patient, okay? If the prostate PSA level is between 4 and 10 nanogram, then the likelihood of prostate cancer is about 25%, okay? If it is more than 10 nanogram, between 10 and 20 nanogram, then the likelihood is much higher, approximately 50% probability that the patient might have. We still have to confirm that through other tests, okay? We can do a digital rectal examination, we can do an MRI, we can do a biopsy, okay? Ultimately, we confirm that on a biopsy, okay? So experts do not recommend biopsy unless the PSA is higher than the cutoff, okay? And the cutoff depends, you know, upon many other things as well. So the cutoff these days, some people say 2.5 nanogram and other people say greater than 3 nanogram, okay? So if you have this, you know, this happens in benign prostatic hyperplasia as well. So depends, you know, it depends upon the evaluation and so many other things, whether the patient should undergo a biopsy or not. Now, another thing, I'll go quickly through these PSA velocity, which is change in PSA levels over time. So what you do 3 consecutive PSA measurements over at least 18 to 24 months, which is about 2 years, and you see how quickly is it rising, or what is the amount of rise in the PSA, okay? So if it rises by 0.35 nanogram per ml per year, when the baseline it was less than 2.5, okay? So this again, just what I want you to remember is that PSA velocity means that over a certain period of time, how rapidly is PSA rising, okay? You do that over 18 to 24 months. So that is PSA velocity. Another thing is bound versus free PSA. Most of the PSA is free. We find it in 2 forms, bound to proteins and free. Now, if more than 25% is free, then we are good, okay? It says that PSA greater than 25, free PSA greater than 25% is normal. It is more than 25% most of the cases. But if the free PSA is less than 10%, then some people recommend a biopsy, okay? So I think this is just, we will have a quick recap. I've given you physical examination and digital rectal examination. I've given you differential diagnosis, bacterial prostatitis, prostatic abscess, BPH, approach to workup, digital rectal examination, prostatic PSA evaluation. These are the backbone of the screening tests, and you have got biopsies, and you have got ultrasound, which is not very reliable. This workup, recommended tests are creatinine, liver function tests, and the tests that are not helpful. And I gave you earlier screening indications, which is family history or genetic background or mutated genes, all right? And then these slides, which are giving you the screening recommendations, they are for your reference only. All right, so we will take a break over here. We'll take a 15 minutes break, and we will come back after 15 minutes and resume the lecture, okay?